Hello, everyone. Good morning. My name is Brendan Coleman. I'm a staff attorney with the Michigan Department of Civil Rights. I'm a white man with short brown hair, wearing a blue suit and a white shirt. I have the distinct pleasure of welcoming you all to the Accessible Healthcare Workshop. This session will discuss how all individuals, including those with disabilities, can readily obtain necessary health services with minimal barriers. Before we get started, we have a few housekeeping matters to review. There are ASL interpreters and CART services in every session. If you have communication issues during this session, let us know. Please identify your name before speaking. For example, I would say, "This is Brendan speaking." The first rows of seating are reserved for those with close vision and fragrance-free seating. If you wish to comment or pose a question, we have note cards on each table to submit questions and staff to collect them. If you prefer to comment individually, please indicate so and wait for a microphone to be brought to you or by an interpreter. After this session, lunch will be served, and box lunches will be made available in the lobby and eaten in the main plenary session. Remember to present your lunch ticket at the lunch table in the lobby. It can be found behind your ID badge. This session will last approximately 1 hour and 15 minutes, and I thank you all for attending. First, I'd like to introduce our panel. We have Dr. Michael McKee, the Associate Director of the U of M Center for Disability Health and Wellness, and the Director of M Disability. We also have Robin Jones from the Great Lake ADA Center, Michelle Roberts, the Executive Director from Disability Rights Michigan, and we also are joined by Representative Sharon McDonald. The full bio for our panelists can be found by downloading the Whova app or by using the QR code at the registration table. Before we get started, we do have a few ground rules for the discussion. Please keep our discussion focused on the workshop topic, and more specifically on the broad policy implications of our discussion. We would like to end this session with 2 to 3 specific policy recommendations to promote accessible healthcare for all. We are unable to address individual complaints or circumstances in this session. There will be time allotted for Q&A at the close of this session, and we welcome any comments with potential solutions for the issues being discussed. As mentioned earlier, note cards are on the tables and can be used for questions. Inappropriate, inflammatory, or disrespectful behavior or language will not be tolerated. Those in violation of this requirement will be warned once and asked to leave. So, first, we're going to start a discussion on accessible healthcare by hearing from Dr. Michael McKee from the U of M Center for Disability Health and Wellness, who's going to talk to us about effective communication with persons with disabilities. Dr. McKee, what are some of the real-world scenarios you have seen pertaining to accessible healthcare and effective communication?
Thank you. My name is Mike McKee, and I want to touch on a little bit about myself. I'm a middle-aged white male. I have a cochlear implant in my right ear, and I identify as a deaf individual. I'm a family medicine doctor at the University of Michigan, and I'm going to explain a little bit about different scenarios. First, I want to thank everyone for coming here. I know, we're living in difficult times right now with everything happening out in the world. And so we still, need advocacy and fight from all of us for healthcare accessibility. It's important for all of us to be supportive and advocate for that. And I want to share a situation I see fairly often in the healthcare setting. We have a deaf individual. This could be a deaf blind individual, hard of hearing individual who uses ASL to communicate. They call the office, they make an appointment with a doctor, maybe it's their primary care physician. They call, they make an appointment, everything seems good, and they let them know that they need an interpreter, and they're told, okay. Maybe that individual shows up to the doctor's office. What we tend to see happen is that there's no interpreter present. The office might say, oh, we're sorry, we couldn't find one, we weren't able to contact an agency, and so now that person, they're in a position of struggle. How can they take care of their healthcare issues? What can they do? And it forces the deaf individual to move into writing back and forth with staff and the doctor. And unfortunately, this is a systematic norm. Some other situations that we recognize are overlooked often are someone who's late deafened or someone who's hard of hearing. Maybe they're a senior and they've lost their hearing with age, and it's very frustrating because they're unable to hear or communicate. And they let the office know, I have difficulty hearing, what can we do? And sometimes they request captions, and sometimes they ask for someone to speak a little bit louder through an audio device. And those people also show up to the office without those accessibilities being present for them. So we see this as a common standard, yet ADA is law, right? We have ACA Section 15.7, the Rehabilitation Act. We're supposed to already be providing these accessible options for communication, for effective communication, and so far we have not been. And those are just some examples. When a person shows up and they force them to communicate in their unpreferred method, and it means that we're going to have communication breakdowns. There's going to be misunderstandings. And definitely they're going to feel disheartened and they're going to struggle. Are they going to trust the doctor in those situations? Likely not. They're not going to want to continue to go to the doctor's office in the future. And we've already done plenty of studies that have found that deaf people are twice as likely to go to the emergency room instead of going to their primary care physician because they don't have accessible communication at their physician's office. And the ER tends to be the wrong place. But they're not getting preventative care, they're not getting preventative services, they're not getting medical treatment. And the emergency room is more for emergencies, right? That's the focus of the emergency room. If you have a heart attack or they're losing different screenings and preventative care access, and this really impacts deaf people in the future. And so if we're not providing, we're not following the law, we're not being held accountable, it impacts the deaf community's health. And everybody's losing in those scenarios. Cost is increasing because we're getting the wrong services. The doctor's office is frustrated. They want help, obviously, but they don't have any idea what to do. They're not trained appropriately. They don't know how to work with individuals with hearing loss. And so I'll explain a little bit more about different strategies on how we can move forward and what to do to fix these issues that arise to support and help that. So it's important, whether it's healthcare, recreation, or religious settings, employment, it's really important that we really think about being proactive. We tend to be reactive. Somebody shows up and there's no interpreter, we try to muddle through it, and the reactive solution is to write back and forth. But if we're proactive, then we can have a plan in place. We can have something established, captions, communication, interpreters. We can have communication be effective and smooth, and we're going to all be more satisfied in those situations moving forward. So we really need to be proactive. Okay, and that I'll pause there and I'll explain more about strategies a little later.
Mike, how can healthcare providers do more to advocate for their patients?
Okay, so doctors in general are not trying to be mean or neglect or, you know, harm relationships with their patients. Doctors aren't trained. They don't have a required training currently. Luckily, the AAMC, who's responsible for medical colleges certifying doctors, and the ACGCE, who's responsible for residencies and fellowships, they both recognize that there's a need for disability healthcare training. So that's been great. We've been fighting for that, and they recognize the need. Which means that we have trainings established now, and we need to collect different training resources. So University of Michigan's been working hard to establish courses, online, in person, patient caregivers, etc., to teach medical students for the future, that they'll become our future doctors. And so we're trying to build that required course load now so that they have that training access. And I'm always meeting medical students, they always shadow me, and I always ask them, how many hours of training have you had in disability health care within your 4 years of college? And I'm just curious how many hours. How many hours do we think? Somebody throw a guess out. Within their 4 year educational training. I got zero, zero, zero. Yep. Well, one. Okay. All right. Oh, 20, 20. Okay. So the range is from 0 to 8. Now, that's 26% of people in America have a disability, right? And so within their 4 year program, they're receiving 0 to 8 hours. That's maybe one day, right? One day of training within that medical school. Now with residency, they've graduated, they're becoming a doctor. They're required to get a little bit more training. And with me, within family medicine, I had 3 years more of residency. So how many hours do you think that we require for disability healthcare? Zero. The ACGME has no training requirement for this. And we do recognize, they do recognize we need to fix that. And so now, when we ask doctors and they don't know what to do, it's unfair, right? But it doesn't mean they're not responsible. It just we need to lobby for change and we need to require training for this type of service within residency, within medical school, and so that we can help open up the opportunities for learning. And students currently want disability healthcare training. They're changing. They're forcing the medical school to change. So I'm thrilled to see that. I'm looking forward to a positive future with doctors and students that are supporting this. And currently, I work with about 30 plus medical students at the University of Michigan, and they want this. They have a passion to help and take care of healthcare in the future for people with disabilities, whether they're deaf, deaf-blind, hard of hearing, in a wheelchair, have an intellectual disability. They really want to take care of everybody. And that's our job. That's our responsibility. And so it's, we're able to create these opportunities for training in the future, which is great.
And speaking, how can patients with disabilities and their caregivers get involved to help healthcare teams?
Great question. So patients themselves, often, they're the expert. So for example, someone with an intellectual disability really teaches us, and it's not the doctor teaching other doctors or other students about disabilities. They're not the expert. So we need the people to come and join our courses. We need the patients, the experts. For example, at the University of Michigan, we have a few opportunities for involvement. We have OSCE, which is objective structuring clinical exams, and that's training for medical staff. And right now I have 7 variants of disability members on the board. There's intellectual disability, wheelchair users, deaf, hard of hearing, blind. And what they do is they meet and they discuss different questions regarding the exam themselves. And they want to sit down and they want to make sure it has different exposure within that exam. And so it's a great experience for them. They need to be comfortable with the uncomfortable. And so this is a great opportunity for us to kind of break down those barriers and move out of that awkwardness and learn from different people with disabilities so that the next encounter can be a lot more smooth. And if you want to be involved in that, you can contact me and let me know, or reach out to the medical school or the residencies, because we do need your feedback. You guys can join along in the process. Maybe you can lecture, maybe you can be part of a panel. You can, meet one-on-one with different students, mentoring opportunities. And so there's a lot of different opportunities there.
This is Brendan speaking. Do you share any relevant policy recommendations that policymakers and advocates might want to consider?
So I mentioned the AAMC and the ACGME, and they're working with the hospital administration, the clinical managers, insurance, that's a challenge. but different policies. We're trying to reach out to all of those organizations to make sure that we're enforcing the law. Right? We have the law there, and we need to make sure that we're enforcing that. Because I think that part is missing, is the enforcement. And so if they're not following the law, then we have to make sure that we're enforcing it. And we're responsible a little bit more for the training side of it. And I have a big belief that we're missing the training, and if we educate more, then people will be more willing to provide access. If they know what to do in those scenarios, then we can have a positive relationship. That we want to help, they want to help, but without that training, it is more awkward. And other doctors might be responsible for providing that, but we really need to avoid the it's not me, it's you, and not having access kind of situation. So it's important that if somebody feels discriminated against or biased or they don't have access there, that they do file a complaint and then they educate so that the next person who encounters maybe that office or that physician doesn't have the same experience.
This is Brendan speaking. Dr. McKee has also graciously provided us with a handout on the topic for anyone interested that you can take with you. Next up, we have Robin Jones, Project Director and Principal Investigator of the Great Lakes ADA Center, to talk to us about non-discrimination in health programs and activities, including requirements concerning medical diagnostic equipment. Robin, please give us some insight into current issues concerning this topic.
Thank you. Again, my name is Robin Jones. I am a 60-something white female with short red hair and wearing black rimmed glasses. This is a critical issue that has been throughout, and everyone looks to the ADA to answer all of the problems and the questions and wants to say, doesn't the ADA require this, or whatever it might be. If you've studied the ADA and know the ADA and how it's structured, the Americans with Disabilities Act, which was passed in 1990, you know that when we look at standards for architectural accessibility and such, it really only deals with the built environment. It doesn't deal with equipment, and that's why we still don't have, standards for accessible bed height at a hotel, and we don't have standards for what a accessible vending machine looks like, or what a chair should look like in a doctor's office, like for a bariatric patient or something of that nature, because that's furniture. It's something that you put in and out. And when you think of accessibility standards in the ADA, I always think of take the building, turn it upside down, and shake it. Everything that falls out is not covered. Everything that's still there is part of the built environment, and it is covered. So when you look at things that we use to provide healthcare, yes, better have the building accessible, better have parking, better have the entrance accessible, better be able to get inside the door, etc. But there's so much more to medical care than just getting in the building. You've heard about the communication issues and the barriers there. So one of the biggest things has always been this issue of how do I get health care if I can't see, if I can't get access to diagnostic equipment and things of that nature to help make decisions or give answers to what might be happening in my life. So we know that participants have a lower standard of health care because they don't receive the same degree of health examination and health interventions as people without disabilities because of the lack of the accessibility of equipment and such. The the Affordable Care Act was passed in 2010 has very specific language in it that charged the U.S. Access Board, which is the federal agency that establishes the standards for accessibility across our various pieces of legislation. They were charged with developing the standards for accessible medical diagnostic equipment. That was 2010. They issued their initial findings in 2017. Now, that's 7 years. The U.S. the Access Board is not an enforcement agency. They strictly create these standards. So they have no power to say who has to follow them. They just say this is what it should look like. The power for that comes from the federal agencies that have enforcement under the ADA, which in this case would be things like the Department of Justice or Health and Human Services, etc. These two agencies did nothing with this, did not move forward, despite calls from the National Council on Disability, from the disability community in general, the National Council on Living, several legislators pushing and saying, hey, we need to do something. These federal agencies need to move on this. So fast forward, got 2010, 2017. Now we got up to 2024. It was the first time that we saw federal agencies move forward with adoption of standards that were enforceable for medical diagnostic equipment. That's only a year, not even a year ago from right now. So we have two agencies that have moved forward in this issue, the Department of Justice and the Department of Health and Human Services. When I'm talking about medical diagnostic equipment, I'm talking about things like examination tables. I'm talking about chairs, examination chairs that might be used by an eye doctor or a dentist, something of that nature. I'm talking about weight scales. I'm talking about mammography equipment or other kinds of diagnostic equipment, MRIs, things of that nature, and X-ray machines. That's just a sampling. There's many other types of equipment that might use specialties and things of that nature. So the rule, the Department of Justice was the first to put their rule out. That was in July of 2024, with an effective date of October 8th of 2024. And what the Department of Justice's standards call for, they only apply to Title II entities, which is state and local government. So it applies to any state and local government entity that operates a medical facility. This would include a hospital, a clinic. It would include a university healthcare system or anything like that. It also includes any programs that they contract for to be done on behalf. So it may not be the government providing the clinic, but they contract with a private entity to provide that service on behalf. This requirement will extend to that private entity because they're performing the service on behalf of state or local government. But that's as close as it gets to the private sector in the Department of Justice rules and regulations. What the requirements that you must follow, the U.S. Access Board standards for accessible, which talks about heights, of tables, talks about the clearance that needs to be available for a wheelchair, mobility around it, etc. Kind of a technical standard. And what it called for was that 10% of all newly purchased after October 8th of 2024, or at least one of each piece of medical diagnostic equipment must be accessible. Okay? So if I'm not buying any new equipment in 2024, I'll apply. The second standard was if I'm a specialty hospital entity, like a rehabilitation facility, a physical therapy clinic, or things of that nature that particularly work with people with mobility issues, then that number goes to 20% of my newly purchased equipment. It does not have a retroactive requirement of having to fix what you already have. It applies to newly purchased equipment. It then has a further requirement that says by 2 years after the rules were issued, July of 2026, at a minimum, even if you have not bought anything in that period of time, you have to have at least one accessible exam table, and you have to have at least one accessible scale. So that's kind of an additional requirement onto this issue. So then this is the Department of Justice, first comes out. Quickly after that, we had the Health and Human Services Agency issue revised Section 504 rules and regulations. So if you're not familiar, Section 504 is part of the Rehabilitation Act of 1973 that states any entity that receives federal funds cannot discriminate on the basis of disability in their programs, services, and activities. So HHS governs all those things that are kind of medical in nature. And so their rules and regulations apply to anyone who receives federal funds and anybody who's a recipient of Medicaid or Medicare dollars. So all of your medical facilities, your clinics, your individual doctor, practitioner, et cetera, who receive those funds, it would apply to. So when you think about the Department of Justice and regulations, it's limited to just those that are owned and operated by a local or state government. You look at the HHS rules, that extends beyond because now it's any private practitioner who receives and takes Medicare or Medicaid. So the HHS rule has a much more sweeping impact, I guess I want to say, in that it will apply to a broader group of people because it touches that individual doctor's office, that individual clinic, et cetera, that's not an operator or not a program on behalf of a local or state government. The same exact rule, they use the same language as the Department of Justice's, the 10% rule, the 20% rule. They also use the same implementation date of October 8th of 2024, and they use the same 2-year rule for minimally having a scale and adjustable exam table. So they do mirror themselves. It's really about how and what they apply, and then of course the enforcement process. Department of Justice's scope for enforcement is different than Health and Human Services scope of enforcement. So these are two huge main areas. If you think about somebody who uses a wheelchair or has any kind of mobility issue, and they go into an exam office or go to a dentist or an eye doctor or anything of that nature, they receive inferior care. You know, if you're not able to be examined, you're not able to get up onto the exam table. If you look at the Department of Justice has several settlement agreements with chiropractors, with eye doctors, with medical providers, et cetera, where they have refused to um, provide assistance even for somebody to transfer onto an inaccessible exam table, saying that it's, you know, drug threat or a risk or whatever. The rules from both HHS and Justice also call for staff training on how to operate the accessible medical diagnostic equipment, as well as training staff to provide individuals with assistance in transferring onto accessible medical diagnostic equipment. Because even if it's accessible to my wheelchair, they may need assistance to transfer over onto that equipment. So, you know, a lot of times we see the medical professionals say, you know, I can't do that. You know, it's a risk. We don't help anybody. You have to bring your own caregiver in to transfer you or whatever. That would totally be discriminatory practice. Nobody else has to do that. Why should I have to bring somebody in? Why would I have to pay somebody, you know, to do that potentially for me? So this is really a huge move forward. It has been a long time in the need and coming. And it's kind of ironic because you would think the very profession that serves people with disabilities, that is responsible for the care of people with disabilities for medical and otherwise, that this would have been something that they would instinctively and proactively and not have necessarily required a law to tell them they have to do it. So we do now have standards. We do know what it looks like to have an accessible scale. We know what it looks like to have an accessible dentist chair or exam table, etc. Now we just need to get our providers to move forward in the purchasing of this equipment, training of their staff in the use of this equipment, and make people aware of the fact that they have a right to ask for this equipment. Because even if I don't and have not purchased the equipment yet, I still have my obligation under 504 and under ADA to ensure that that person has access to medical um, services in a non-discriminatory manner. So I can't even really hide behind the requirement that says I have until 2026 because I still have an obligation to serve that person. So it really is uh, a change significantly, and medical providers are somewhat scrambling to do this. And at the same time, we've got that supply and demand issue, and that you've got to get the manufacturers to be able to meet those standards. And of course, anything that has the title accessible on it costs more. So I always think back to the days before the ADA when you went to buy a levered handle at Home Depot or Menards or whatever. It always costs more than the round handle. And that was because that was seen as special equipment. It was, not mainstream equipment. Now, because it's in the standards, it's required that you put a levered handle on all of your doors. Well, guess what happened? The price of levered handles is the same as round handles because it's applied in. So that's also something that is going to have to shift and change. There's a lot of concern about the new tariffs that are happening right now because a lot of medical diagnostic equipment is uh, manufactured overseas. It's not manufactured here in the U.S. And that cost associated with that equipment, this new mandate and new requirement, obviously can be problematic. So we should be starting to see October 8th of 2024 passed. So we should start to see more accessible equipment, but we need to demand it as people with disabilities in the community, as people who are caregivers of people with disabilities in the community. We need to demand of our providers. Don't let them slide. The ADA has been around for 35 years as of this July. And I can still tell you, I go out every day and see storefronts that are not accessible. And I see, parking spaces that are not accessible or whatever else it might be, or bathrooms that are not accessible. 35 years later, right? So not until we demand that these entities meet these requirements and we make sure that we know our rights to demand that. Are we going to move the needle in the healthcare arena to actually meet these standards? Because as I'll always say, rules and regulations are only as good as the piece of paper that they're written on. They've got to be enforced. They have to be put into place. We need to demand and educate the people that we're working with or that are providing services to us that we have a right to that, and we're going to demand that they do that. We need to go to our insurance companies, and have them put pressure on this as well because it is impacting me. My quality of health and my need for health care insurance is going to be directly correlated to how good a health care I get. And if I don't get weighted, nobody knows how much I weigh. How are you going to do an accurate dosing of my medications? If I can't get on an exam table, how are you going to actually look at my skin to see whether I have any skin cancer or skin breakdowns or things of that nature? If I can't get an x-ray, how are you going to see whether I have a bone that's healed or not? Such. So these are all, or if I can't get a diagnostic test for mammography, is it likely that I'm going to have die from breast cancer because it wasn't caught early enough? Because I don't have access to diagnostic equipment. So these are all really critical things that we need to keep in mind, keep pushing forward. And again, the rules and regulations are there. They're supposed to have teeth, but the teeth is in us as individuals demanding our rights and our access to this information and continue to educate the public about the need and their responsibilities to provide it.
This is Brendan speaking. Thanks so much, Robin. For those in the audience who want to be part of the solution, what can individuals do at the local, state, or federal level to help improve access to equitable health care for people with disabilities?
This is Robin speaking, and again, this is as I go out and I seek my healthcare provider. Some of us, we go out and we choose. Yes, it depends on where I live. I may not have a lot of choices. Unfortunately, because of how our insurance system works, I may not have as many choices if I'm in an HMO and I have to use a preferred provider or something, of that nature. I can't pick and choose. But I want to be educated for myself. I want to be asking the questions when I'm picking that plan. When I'm looking at, I go into my employer. Is my employer, making sure that the choices they're making, for who my providers are proactive in these things. So you have to be your own voice. We need to be educate ourselves first and foremost. What is required? Who's required to have it? And then make sure that we ask for it and that we demand it from the provider that we're receiving our services from, and that we then also hold them accountable and file complaints if we need to file complaints. Don't wait for the next person to do it. Each and every one of us are the police force. There isn't just one entity out there. There's no proactive process for evaluating whether or not an entity is in compliance. We are that police force. We are the ones that need to bring it forward that um, there is a need and you need to follow that or I better file a complaint.
This is Brendan speaking. Thank you, Robin. Our next speaker is Michelle Roberts, the Executive Director of Disability Rights Michigan. Michelle's going to talk to us about accessible health care with a focus on mental health care access, affordability, and policy. Michelle, tell us about an issue that you have commonly observed when it comes to accessible health care and the potential policy implications.
Thank you. Good morning, everybody. I'm Michelle Roberts, and I'm a middle-aged white woman. I do identify as a person with multiple disabilities. I have shoulder length, dark brown curly hair, and I'm wearing a black suit with a floral black top underneath. And I will be using my cheater readers to help me as I need to refer to my notes. So one of the common scenarios that we see is an individual of any age who has a mental health or behavioral health needs finds themselves in a crisis and either themselves presents to an emergency department for help on their own, or after perhaps law enforcement or emergency services have been called by either a family member, maybe a neighbor, they've been called to intervene. And one of three things tends to happen. One is the individual is assessed for safety and risk, and it's determined that they don't require any sort of inpatient hospitalization. And so they're released with a recommendation that they follow up with their local physician or their local community mental health provider. And there's an issue with that scenario where there's a lack of ability to access behavioral health services in their community. And there's a lack of home and community based services to support them in their community. And there's a lack of direct care workers, which we heard a little bit about earlier today. The second thing that can happen is that the individual is held in the emergency department and ultimately petitioned into the hospital for psychiatric care. This then runs into issues with discharge planning when they have reached a level of stability or recovery where they're able to return to their community. There's a lack of coordination of aftercare services and supports to safely re engage that person and welcome them back to their community. And so when that happens, there's a gap between when they leave the hospital and they are able to then access those services. And you'll see there's kind of a common theme in all of these, in addition to some of the policy recommendations. The third thing that tends to happen is that the individual remains in the emergency department for an indefinite amount of time without being assessed, without being treated, and having been identified, needs, significant needs for services identified, which can be provided in the community, but they remain at the emergency department for a month or even longer while they await coordination of services, either in some sort of congregate or institutional hospital setting or in the community, which then backlogs the emergency department, delays them returning to their community, delays them receiving services. And another issue that is prevalent in these is that there's a lack of psychiatrists. And so the lack of the ability for people to be assessed timely, to be coordinated and set up with services and supports to serve them in their communities when they're able to be served in their communities, all of that is delayed. And then if they do require inpatient hospitalization, they languish longer than necessary because they can't get that coordination of services so that they can get back to their communities. And so this happens, we tend to refer to this as like the hamster wheel cycle. So someone languishes in the emergency department, and then you've got more people presenting to the emergency department. People can't access services in their communities from their public providers. And so then they decompensate or have run into crises where they need to present to the emergency department just to get help. And then they're hospitalized, but then they can't get out, which causes a backlog of people not being able to then get in when they do need that level of care. And so there's this sort of vicious cycle that self perpetuates because we have a broken system and it's not accessible to people. So perhaps it's not accessible in a different way than what we've been talking about as far as not being able to necessarily communicate with people or physically get into the buildings and so on, but it's inaccessible in many other ways.
This is Brendan speaking. For everyone else here wondering how they can help with the issue, what are some things that people can do at each level of government?
This is Michelle speaking again. That's a great question. Number one is get involved. have conversations with people so that people can understand and learn about people with disabilities, including people with mental illness. There is such a stigma, as we all know, about disability, and as long as people think, why don't I don't disability isn't a part of my world, why do I have to care about this? But when they get to know people with disabilities and they learn that people with disabilities are we're everywhere. They're my colleagues, they're my neighbors, they're the gentleman I sit next to at church. They're the people that I'm in the line with at the market. They're regular people just like everybody else. When people start to recognize that and understand that, that's when some of that less than and othering will stop because they won't see themselves as different from the rest of us. That's one thing. Another thing is to get involved by talking with your elected officials and people who make decisions about policy and laws that affect all of us. Right now, as we heard about earlier, there's a huge attack and fear about Medicaid being cut and services. And those Medicaid pays for those home and community based services so that we get to live in our communities, in our own homes, where we all have better health outcomes. We all prefer to live in our own homes where we can still be a part of our communities, our families, our friends. It's the most effective, it's the most cost effective. But if we lose that, it puts all of our communities at risk. Whether you are a Medicaid recipient or not, it puts you and your healthcare services at risk. And our state cannot support current levels of Medicaid without federal funding. So just yesterday from our governor's office, I had gotten a report that 2.6 million Michiganders are covered by Medicaid. That's more people than the entire states of New Mexico, the state of Nebraska. It's nearly the entire state population of Mississippi. That's a lot of people just in Michigan. And so if we lose Medicaid, we lose a whole lot, and that makes everything more expensive for everybody else, even if you don't use Medicaid for your health care. We are working really hard and need help to try to professionalize the field of direct care workers. There is such a decision that has to be made by people who want to work in this healthcare field, but they can't afford to support themselves or their families. They don't get health insurance, they get low wages. There's high demands of the job. And when you have to make decisions about putting food on the table for your family and paying for medications and electricity for yourself and your family, you're going to take the job that pays more and gives benefits, and there's opportunities for advancement and education, which means you're going to take the job at fast food or a local retailer versus where your heart really is working with and supporting other people to live in the community. You're not going to take that job, and that has to change. We also want to see that psychiatry is promoted as a viable and valuable career. There is a massive shortage of psychiatrists in our state, and if people don't see a value in people with mental health and behavioral health needs in the medical field, they're not going to go into that field. If they can't earn a living doing that, they're just not going to do it. And so, that's another way of getting involved in talking with Dr. McKee about some of these. Um, the ideas about giving training to medical professionals and physicians about disability that includes mental illness, and there has been a lack of interest in going into the field of psychiatry, and we need to change that, and part of that is getting involved and having those conversations. Another thing that can be done is to help rally to reform and improve our public behavioral health system. It is multi-layered, it is very expensive, it is inconsistent across the state, it's complicated, and it's difficult to access, in addition to being very expensive. And we need to change that. It needs to be accessible for people. It needs to be consistent throughout our state, regardless of where you live, that you can access the services that you need, that those services can be nimble to meet your needs as they change, as your health and your healthcare status changes and evolves. We're not all the same every single day. And there needs to be removal of the financial disincentives by the sort of this conflict that is set up by the way that our current system is structured. Those are some ways that folks can get involved.
This is Brendan speaking. Thank you. Last up, we have Representative McDonald here to discuss some proposed legislation. You have the platform.
Thank you. Hello, everyone. I am also a 60-something-year-old woman. I am short and have shoulder-length blonde hair and glasses, and I'm wearing an olive green jacket today. Um, this is a first for me. I was intending to come to this conference to learn from all of you instead of be speaking. But I do want to share a little bit about myself. I chose this panel to speak on because I do have experiences with healthcare accessibility. Before the ACA went into law, I was often my mother as a mother with a child with a chronic disability. I've had rheumatoid arthritis since I was 4 years old. We were repeatedly refused health care over time because I was considered too expensive to cover. I've had multiple surgeries. I take one of the most expensive medications on the market. So when my husband's small business was doing poorly, I had to stop being a stay at home mom so I could get a full time job to afford my own medications. Um, I have a daughter in terms of Medicaid. I have a daughter. Today is her 22nd birthday, and she was just finally diagnosed on the ASD, the autism spectrum, about a month ago. It took many years to get that done, which is a wonderful thing because now we applied for Medicaid for her, and she is eligible at a time when Medicaid is in great danger of being cut. So I do have some experiences with this. And speaking of, also a member of my family with mental health care issues, and something that we have fought for often, especially the last term when my party was in majority. We fought very hard for mental health care parity, and we were not able to succeed working to get mental health care to be treated as seriously as mental health care to be treated as seriously as medical health care. But we will keep working on that. Um, I am I represent District 56 in Michigan, which is in Oakland County, Troy and Clawson. I am the chair of the Michigan Legislative Disability Caucus, which we also call MLDC. Um, Brett Williams of the Michigan Developmental Disabilities Council has been very helpful to us getting that up and running and keeping it going. We hold monthly meetings that are virtual so that everyone can be included. Our monthly meetings include legislators, self advocates, subject area experts, families, and service providers. If you reach out to my office, we can easily have you come and join us in our monthly meetings. They're every second Monday at 1 o'clock. And you can find me, Sharon McDonald, online pretty easily and get a hold of my office. Um, the purpose of that group is kind of a policy incubator. We both have presenters who share information with the community, but we also have the community and self advocates speaking back to us to make sure that we are on track with what we're talking about, what we think what we're up to, and the legislation that we are pushing forward. Um, I have worked to um, try to make life better for people with disabilities. I've sponsored the upgrading of my Able Savings accounts, and some of you may know about the Justice for Ally legislation that made online sexual exploitation of vulnerable adults illegal because before that it was not illegal, um, which is not good. So people are not always paying attention to the rights and needs of our disabled community, and we're doing our best to make sure everyone is being heard. Oops, I jumped ahead. I'm sure you'd rather hear than my personal story more about legislation that we're working on. One thing is called the Everybody Can Move legislation, and that would excuse me, would require insurance companies to cover prosthetic devices beyond kind of the generic prosthetic devices that people with missing limbs may may be prescribed. The idea of this bill is that children and adults um, do not have access necessarily to um, looking for the right terms prosthesis that helps them be more active, like higher level prosthetic limbs that can help children not just walk to their classroom, but also run and play on their playground. So we're working on that. We believe it's possible this legislation could become law this term. We're also working on a motorized wheelchair users bill of rights. If anyone has anything to share with my office, please let me know. This idea actually comes from farmers, where farming equipment often um, farmers can't fix their equipment on their own because they're not allowed manuals that show how to fix it. They're not allowed parts and sometimes software that they need to fix tractors and farm equipment. The same is true with motorized wheelchairs that and sometimes when people have to send away a wheelchair to get fixed, which could be weeks at a time, they're losing their mobility. So that is something we're working on, and we would be happy to hear more from anyone who would like to make sure we're on the right track with that. We're always very happy in my office to share the legislation drafts we're working on and to get input from everyone who is interested. Um, we're also have heard kind of the alarm bells about Section 504, and that the last I heard, 17 states attorneys general are trying to sue to end Section 504 in America. Um, they are claiming, these attorneys general, I'll read from my notes, claim that their lawsuit was motivated by the former president interpreting Section 504 to include gender dysphoria, which obviously is a hot political issue. However, the lawsuit itself does not ask the federal courts to remove gender dysphoria from this lawsuit. The lawsuit, even when the people who are bringing it are saying it wouldn't hurt people, they still are refusing to take the wording out of the language that would have Section 504 completely eliminated. Um, so that's something we have actually are getting help from, perhaps. Ms. Roberts on that issue, and we're trying to figure out. Some people have told us we don't need to codify Section 504 in the state of Michigan. Others have told us we do, so it's something we're really working on right this minute. Um, and we also have worked on, we're working on the idea of 14C certificates, which are also called sub-minimum wage. This is an unfortunate thing. This year, we're ready to start gangbusters on a work group on this issue. Basically, I think we don't have to argue whether some minimum wage is going to go away. We're pretty sure that it is. So my office and I believe that the issue is more how do we ensure that people, if and when 14C certificates go away, how do we ensure that people who now have a place to go, a social place to go, have things to do during the day, how do we ensure that they do not lose one of the most important things in their lives because those jobs are wiped away? Maybe they don't have to be jobs in the future, but how do we ensure that we don't remove an important social opportunity from many of our community? So that's what's important to me. The reason I say it's unfortunate is that because there's so much concern, fear of losing Medicaid or massive Medicaid cuts, that people, the providers and people who are interested in being on this work group are currently too busy making plans for every possible occurrence with Medicaid, and they really don't have time to. This has become kind of a luxury issue when some people and providers feel that we may be fighting for our lives. Just two other quick things. I'm not a sponsor, but I'm also very interested in the Prescription Drug Affordability Board, which would be a statewide board that we would set up if this legislation passed, where they would work on lowering the price of prescription drugs and also putting caps on medication. I said before that I take a very expensive medication. It is currently $8,000 a month. So if I don't have decent insurance, because since it's attached to my job, I don't get that medication. Just one other thing, I'm gonna say something that's just I think our first speaker today in the morning kind of inspired me to think about something that I'd like people to think about. I'm one of the I guess I would have to say admit that I'm one of the champions of disability rights issues in the legislature in Lansing. And I only say that because um, we're coming up on another Mackinac policy conference. 2 years ago, I went to my first one because I have rheumatoid arthritis. I had a bad flare in my foot, and it was extremely difficult to get around. Um, as you know, there are no cars, there are no electric vehicles, there are only horse and buggies, and walking and getting on a boat to go across to get to the island. It's intentionally exclusive, um, but it also excludes many of us. Last year I had a torn ACL. I couldn't go. And this year I just don't. I had to get a new knee. So I don't feel like I'm physically ready to go to the Mackinac Policy Conference and do 15,000 steps for 3 days. I think that's a problem. And I think it's a problem that people should talk about. Because I should be there talking about disability issues. And I can't because I have a disability. And a lot of you who might want to go and be part of that opportunity, it's really hard to get around there. It's not made, I mean, it's intentionally exclusive and it excludes me. Um, so I think there might be something we could fight over about that, or at least bring attention, and perhaps the organizers of it could help make it more available. One story from that: when I was there 2 years ago, I asked for an elevator to get to a hard to reach floor. Somebody told me there is no elevator. I had to go up 2, 3 flights of stairs. The next day I said, are you sure there's no elevator up there? And they said, oh no, there's an elevator. And I said, why didn't you tell me yesterday? He said, because that's only for people with disabilities. Well, surprise. So the people aren't trained either to deal with that. So it's just really not open to us. So I think we should try to make some change there. So thank you very much.
This is Brendan speaking. I want to thank all of you personally for being here and for all of your contribution. At this time, we're going to move over to our Q&A section. So we're going to turn it out to all of you who are here, and our liaisons are going to circulate the room to help facilitate. Please wait for a microphone and or an ASL interpreter to come over and make sure to identify yourself before speaking. Looks like we have a question coming from the middle here.
Good afternoon. My name is Dessa. I am a white woman in a wheelchair with long blonde hair wearing a red hoodie. This question is for Dr. McKee and Robin. Just both of you mentioned some exciting progress, but I just wonder if the programs at University of Michigan Medical School and the rules from HHS and DOJ they seem like they would be directly in conflict with the attacks on diversity, inclusion, equity, and access, and wondering if you see those things under threat and what you anticipate coming.
Start, this is Robin speaking. Um, Disability is not um, DEI. I mean, and we have to continue to put that out there that disability is, you know, not part of that woke and all of the other things that are happening, are being spoken about, et cetera. So we just have to continue to press the fact that disability should not be uh, caught up in those discussions and things of that nature. Disability is part of the human, um, condition, et cetera, that people have, and that's just an ongoing issue that we have to continue to educate about. We are at risk with 504. You heard her talk about the lawsuit, Texas versus, I can't ever get the whole name of it. You have, I think, a copy of it on your table, et cetera. Um, if 504, the HHS 504 rules are struck down, that will not just be the gender dysphoria and issues that, et cetera, that kind of started that process. It would be the entire 504 rule that was issued in 2024. That's what they're attacking. Um, and so that would include the diagnostic medical equipment rule as well, since that's part of that 504 rule. So that is obviously a lot of concern. The DOJ rule at this point has not been subject to any attack. I think you should be aware, though, that the disability rights section of DOJ has been dismantled. The staff are no longer there, et cetera. In the reorganization of the Department of Justice and the Civil Rights Division of which the disability rights section is a piece of. We don't know where that's going to happen, but we do know that the staff are gone. That have done that. The TA line is still operating, but there's no attorneys and no other folks currently there. So the enforcement process is up in the arm right now. So again, as I said earlier, the law is only as good, or the regulations as good as the piece of paper that they're written on. And it's going to take the enforcement process. And we're being told that they're going to continue to force it. May not be within the disability rights section as it's no longer existing, but we know that there's no expertise elsewhere in the division, and there's other priorities that they have, such as immigration and other things that would probably trump any enforcement from the ADA side. That's why I think it's really important from a policy side is to look at our states and see, can our states incorporate these things into their state laws, because we've seen from the very beginning with the ADA, as states have, Michigan being an example of that, has strengthened its civil rights laws to mirror a lot of the same protections that the ADA has for employment or has for places of public accommodation and such of that nature. We need to look at how can we strengthen our state laws to take over where the federal law may not, because of the problems that we're having. But it's still a very big unknown as to where it will go. They're so new, that there really isn't a good crystal ball yet as to where that will be. But we do anticipate that in general, already seeing it, the enforcement of the ADA in general and the enforcement of Section 504 in general right now are pretty much stagnant.
This is Mike. And just to add a little bit more to what Robin had shared, I'm a big supporter of DEI as well. So, I disagree. We are not included in part of that, but at the same time, healthcare focuses more on the equity part, and inclusion and advancement. And so we're all struggling with basic access here. And so when we really think about all of us, priority is accessibility. And accessibility itself really starts to open up all of those other opportunities that you get within healthcare. And, we understand there are threats against DEI, uh, and I am a big supporter of pushing back against those threats. We can't just focus and isolate and, only focus on disability alone. And so myself, I am identified as a deaf person, disabled. My mother is Hispanic, and so we have strong ties to the Hispanic community. And so it's not just about disabilities, right? That's not the only focus. We're very layered. There's a lot of different communities that we're a part of. And so for myself, I want to show support to all of those communities and work together and fight for access. And at the same time, the University of Michigan right now is focused more on healthcare advancement. And that's really where the priority is currently, is to make sure that all of us have access, that we can have access and get health care, and specifically people with disabilities have specific needs. We need to identify those needs. We need to recognize those needs, and we need to collect information like your age, your gender, your race. When we're collecting that information, we don't typically, recognize the disability, and we're trying to change that. It's part of the demographic of that individual. Within the healthcare system, we really need to be requiring that. The government needs to also support that as well.
Question.
I would rather hold it, please. Good afternoon. My name is Shayla Lung. I'm a Afro-Latinx Chinese female in the late 20s. My hair is in a bun and I'm wearing a purple shirt. I have two questions. The first is going to be for Dr. McKee. In regards to the initiation for additional education required with the fulfillment of a medical ship, there are two parts that I ask. The first is it possible for the medical industry outside of after education just initiating a new process where engaging with a patient instead of pleasantries, hi, how are you? What brings you here? After those pleasantries, can we train all physicians and staff at all points of contact, inquiring what has your experience been so far, and what are you hoping to achieve with today's visit? It follows the same practice with therapists as the need is for psychologists. However, that ties into what if the medical industry requires that in maybe an additional year where they are required to take psychologically tongue tied psychological classes that a psychologist would have to fulfill in their PhD. Would that not eliminate the issues that we see at the employment levels, the public access levels, and also changes the requirement for an education status because the way that we have learned and data has increased with more diagnosis requires additional training? Are those two ways that we could eliminate and help the disabled community at all points?
This is Mike here. So, a few
Thanks.
ideas. First, it's that screening process. It's being able to ask questions and document to help that process along. When we get that patient's information, before they meet us in person, and we can see the medical information in the chart, we might have some background with that regarding that person, but we tend to go in and it's kind of awkward. Hello, you give your name. I know you have you identify with a disability, and we want to make sure your healthcare is accessible. What can we do for you so we can learn from them? And so when we're, teaching the medical students, we're teaching them how to approach, how to be comfortable in those encounters so that they can be comfortable moving forward. In addition is, understanding their legal obligation as well. It's just like running a business. If you have no idea about business law, just the same as a doctor, if you become a doctor, you're running a business as well. So we're asking them to get that additional training and emphasizing that training, and it should require some communication, just basic communication needs, right? That's a basic concept, but we're not always teaching that. And, look at the patient in the eye, and maybe I'm unaware of their disability, but do you mind educating me on your disability so that I can partner with you? It's kind of that, just cultural humility. It's important to teach that. We don't expect everybody to become an expert within the medical field, but, an expert on all disabilities, but we need to be human, and we need to be open, and we need to be, able to be educated. And I'm sure the rest of the panel can add to that as well. I did have one addition. We have a disability healthcare fellowship. We just established it recently. And again, that's within family medicine practice. We get some training. We understand there are unique needs there. And it's just a 1 year fellowship. It's the first in the US. And it's just general disability training. And we need more opportunities for them to be able to learn and interact with their primary care physician so that we can, recognize different disabilities that we might see. And so we have to be able to establish those opportunities within medical school and the fellowships and the residencies. You need to ask your local hospitals to support that as well. I think we have another question over here.
Hello, my name is Odessa Carson. I'm a black woman and I am in an all green suit and I have my hair down. And my question is that I have a very close relative of mine that has Medicaid, and we often find that many physicians and doctors do not accept Medicaid. So I was wondering if you all know of any other healthcare or funding resources for people with disabilities, whether it's intellectual, physical, or et cetera.
This is Michelle. Are you asking if there is other funding for for healthcare for people who have Medicaid, but physicians and such are not taking the Medicaid insurance? Okay, very good. Thank you. Um, I don't. I'm sorry. I don't.
Lee, we do have to cut off the Q&A because we're just about out of time. First, could everyone join me to give a round of applause to all our speakers? They were wonderful. As I mentioned earlier, we want to end the session with 2 to 3 policy recommendations. We had staff taking notes to capture any practical solutions discussed. And these policy recommendations will be reviewed by the Civil Rights Commission, the department, and our partners to try to drive change in the state of Michigan. We'll now have a 15-minute break before the lunch plenary begins in the main plenary area, and box lunches are available in the lobby. The lunch keynote will begin promptly at 1:15 p.m. Remember to present your lunch ticket at the lunch table in the lobby. Feel free to walk around the exhibit tables. We have organizations that want to share resources and information about what they have to accomplish. For those that may be feeling a little bit overwhelmed, we do have a sensory room available located on the first floor in the venue. Just look for the sign or ask any staff member here. Thank you all for joining us. Sincerely.